Ragazzi, bienvenue. Grüezi ragazzi, bienvenue and willkommen to one of these Tuesday LinkedIn Live. My name is Viola Brugnatelli. I'm actually the co-founder of Cannabis. Cannabis' goal is that of providing the support for the much needed cultural and societal change for the reintroduction of cannabis in healthcare, in medicine. And we believe that without the support of education, it's going to be really hard to have cannabis back in healthcare. So, in order to really support this change, there we are. Every Tuesday, we are organizing these events, but also we do a bunch of other things. So you can check out our services if you are interested to understand how education can support your business, your company, your clinic, your whatever pharmacy, whatever it's your point of view within the cannabis field or not, or the healthcare. And today, as I said, we have a lovely guest together with us, with Fabio Turco, who is the scientific director, is here with me. And then we have also a lovely guest of today's live, who is Dr. Valeria Giorgi. Valeria will talk today about fibromyalgia. What an interesting pathology. It took us such a long time to start to find out something about fibromyalgia and even more to understand how to treat it. So it's going to be very interesting. Actually, Valeria has been supporting our work and throughout already from a while, because thanks to Valeria, we managed to gather some of the case studies deriving from her own experience with patients, and her case studies, together with that of many other doctors around the world, is now comprised in the book that we recently launched, Principles of Clinical Cannabinology. And of course, if you're watching this on your desktop and you have your mobile on your hand available, you can also take a picture to our QR code, and you should be able to reach the place where the handbook is and follow along with all of the good jazz. Now, I won't take any more time, so I will want to pass the mic to Fabio, the CSO, and enjoy. I just wanted to remind you all that this is live. So, of course, if you want to interact with us, you're more than welcome to do so. Please send us your questions, and I will make sure to moderate those and make sure that they will reach the ear of our guest today. And enjoy. It's going to be just half an hour. So let's go.
Okay, thank you, Viola. Good afternoon to everyone, and welcome to this live event on LinkedIn with the Cannabis. Today, our guest is Valeria Giorgi. She's a medical doctor and a researcher specialized in fibromyalgia. In this discussion, we will explore the challenges associated with treating fibromyalgia and the potential role of medical cannabis and cannabinoids in alleviating its symptoms. And this is really an hot topic. Indeed, a few days ago, an article was published which analyzed the data from the UK Medical Cannabis Registry regarding the use of cannabinoid treatments for fibromyalgia. The study concluded that patients who underwent cannabinoid treatments experienced improvements in their symptoms. Moreover, these treatments showed positive effects on various issues related with fibromyalgia, like sleep pattern, anxiety levels, and the quality of life. So this research, like many other, further underscored the potential of cannabis and cannabinoid in treating fibromyalgia. That is a very peculiar condition characterized by both physical and cognitive impairments. So understanding the nature of fibromyalgia and its complexity is crucial for an effective treatment. So my first question for Valeria. Can you briefly explain what fibromyalgia is and why it's so challenging to treat?
Yeah, so thank you. First of all, thank you very much for the invitation. I'm so glad to talk about this topic. which I've been researching on for just a while. I'm young, but I'm doing just that. So it is a very, very controversial topic still, but more and more research has been done about this pathology. So basically, fibromyalgia is a syndrome, so it is a cluster of symptoms. It is not the dignity of a disease yet, but it is a cluster of symptoms. So basically, it is like IBS, or irritable bowel syndrome. The cluster of symptoms is very big, but the most important ones are three. It's a triad, which is the chronic widespread pain, and we have chronic fatigue and sleep disturbances. So this is basically the core of fibromyalgia, but we have a lot of other symptoms that characterize the syndrome that aid diagnosis, because diagnosis is purely clinical because we don't have biomarkers yet. So other symptoms that characterize this syndrome are, as you said, cognitive disturbances, which may be very prominent in some patients. Then we have mood disturbances, and we have some autonomic dysfunctions. So we may have orthostatic hypotension, dizziness, vertigo. We may have instability. We may have difficulties in focusing. We may have the syndrome sicca, which is dry mouth, dry eyes, dry mucosa in general. So this is a very complex condition. We may have different symptoms in different patients. So most of the times it is confused with other pathologies, of course, and also it is very concomitant with many other diseases, so mostly rheumatological diseases. And if you see, it is very common in the connective tissue disorders patients. So it is very, very difficult to diagnose because still we don't have a biomarker. The other problem of fibromyalgia is that we don't know why these people feel the pain, and we don't know why these people have this whole lot of symptoms. So we basically have, nowadays we have a definition of this type of pain, which is nociplastic pain. So basically, nociplastic pain is the third descriptor of pain, which have been developed in last years by researchers, mostly from the IASP, which is the International Association for the Study of Pain. They defined nociplastic pain as a dysfunction of the nervous system. It is a dysfunction of the system which provides us the information, which then we kind of interpret as painful or not. So it is a dysfunction. It's not a lesion as neuropathic pain, and it is not the pure information of pain, which is nociceptive pain. So this is a third mechanistic descriptor of pain. So nowadays, all the so-called idiopathic chronic painful condition fall under the realm of nociplastic pain. It is not, mostly it is mistaken with pain of unknown origin, but it is not of unknown origin. It is nociplastic pain. So, of course, the problem is why these people develop nociplastic pain. So it is not a pure lesion of the nervous system, as it is a neuropathic pain, as it happens, for example, in the post-ictal pain. So there are some hypotheses going on, but basically what is clear is that there is a sensitization of the nervous system. And this sensitization is a purely physiological process that then happens pathologically in some diseases, in some conditions. So what do we mean with sensitization? So basically there are two different pathways that are activated. So it is a centrally derived mechanism and a peripheral derived mechanism. Of course, the central one is mostly due to the central nervous system. So we may have traumas or stress, mostly traumatic conditions. And then we have sleep disturbances, which are very, very important to in a way cause the chronic pain, and psychological disturbance and psychological problems. For the central, these are the most important ones. For the peripheral ones, we don't talk only about the peripheral nervous system, but everything that's in periphery of the central nervous system. So we also have the muscular tissue, we have the immune system, neuroendocrine system. So as we said before, we have a lot of autonomic disturbances. So there is probably something going on in the autonomic nervous system, and some researchers hypothesize nowadays that maybe it is an autoimmune disease of the peripheral nervous system. And in the last months, researchers have identified some of these autoantibodies, especially in a subgroup of fibromyalgia patients. And then we have the interaction with immunity. So we now know that fibromyalgia patients have low-grade systemic inflammation, and it is mostly connected with the gut. So it is due to the increased the hyperpermeability of the intestine, which then kind of sensitizes the immune system, and which becomes very much activated and causes this low-grade inflammation systemically. So we have a lot of problems. So also, of course, in the gut, we have a lot of food intolerances, and also this sensitization can be seen also with other type of stimuli. So we do not have only hypersensitivity to touch, which is called hyperalgesia or allodynia, but we also have hypersensitivity to other type of external stimuli, such as light or some odors or noises, and we have also hypersensitivity to some drugs. So then we'll talk about it later on. But basically, the problem with fibromyalgia is that we don't really know why these people develop this kind of hypersensitization. Probably there is not just one type of fibromyalgia. This is a syndrome. So we can see that it is very prevalent in those inflammatory autoimmune conditions of the joints, mostly. So the rheumatological condition, we have a lot of fibromyalgia patients. So even 20 to 30% of arthritis patients have fibromyalgia, and up to 60% in some studies of connective tissue disease patients have fibromyalgia. So probably the sensitization is due to this inflammation in the periphery and the activation of the immune system.
Thank you, Valeria, for this explanation. Listening your word, we can understand how complex is this kind of syndrome that involve a lot of organs and system in our body. Moreover, it's interesting that fibromyalgia, we are discovering that fibromyalgia, like other condition, probably starts from the gut, and it is due to this gut-brain axis connection that seems to be involved in a lot of conditions. Like now, scientists are seeing a connection also with neurodegenerative diseases like Parkinson or Alzheimer, autism, and so on. So this is, I think, a really important topic that should be further addressed. Moreover, among this complexity, we have seen that fibromyalgia is characterized by pain. So probably this is why medical cannabis and cannabinoids can be effective in the treatment. So my question is, why and how medical cannabis and cannabinoids can be effective to treat the symptoms related to fibromyalgia?
So medical cannabis can aid in a lot of ways. So of course, analgesia is very important because these patients suffer very much pain, and it is not very well controlled with the normal medications. So basically, what we use for fibromyalgia are antidepressants and mostly SNRIs, which modulate the descending pathway that inhibit the nociceptive activation, but they are effective just in 30% of the patients. So maybe medical cannabis can be an add-on treatment or a treatment by itself if any other treatment doesn't work. So the analgesia is very important, and there are a lot of there are different opinions, because the problem also with cannabis is that there are not many randomized clinical trials that have been done. But with fibromyalgia, we have a few, and we saw that THC may be important for analgesia in this type of population, but actually many of my colleagues, for example, that work with cannabis and fibromyalgia, say that starting with CBD may be better. This is because of different mechanisms. So as we saw before, the low-grade systemic inflammation is very important in this population. So maybe the modulation of inflammation at the beginning without addressing directly the pain, so the painful pathways, may be more important. And also the modulation of the inflammation which is present in the gut. So probably the oral absorption of maybe the CBD can be useful even by itself. And then we have an important modulation of sleep and anxiety, which are able to really increase very much the pain. So nowadays we know that chronic sleep disturbances are able to cause chronic pain. So once it was believed that it was the other way around mainly. So I have pain, so I cannot sleep. So pain causes sleep disturbances. But actually nowadays we know that sleep disturbances and chronic insomnia, but it is not just insomnia. Is a kind of, again, kind of autonomic disturbance here. So we have kind of little arousals during the night, so we have an unrefreshing sleep, and at the end of the night I feel that I've not slept at all. So the modulation of sleep and in aiding sleep, of course, increasing sleep quality may be an important mechanism by which cannabis helps out this type of patients, and also modulating the kind of the anxiety and all the psychological disturbances that these patients go through. So I must say that probably analgesia is just one of the mechanisms by which medical cannabis can help these patients.
Thank you. Thank you for giving all of this explanation as well about the etiology of such a complex disease. I just wanted to add myself in here because I think we touched such an interesting topic actually on what Ethan Russo calls the endocannabinoid deficiency. So it's a mere correlation. We cannot, it's just a mere correlation of pathologies that show exactly these traits. So pain disturbances, gut disturbances, mood disturbances, and pain usually relate to a deficiency of endocannabinoids. And so that's how, therefore, it can be useful, a cannabinoid-based therapy. But I agree, and I've seen it from your case studies and from other doctors as well, that just the high THC approach, because of the mood, then of course, as you said, it's a spectrum, but because of the mood disturbances and also of the sleep disturbances, could actually have some detrimental effect just going direct in with a plus than 20% THC type of variety. Whilst I've seen as well from the way you treat your patients that there is a tendency to actually find a balance more in like 1-to-1 ratio, or like a more balanced type of approach. And I wanted to just ask a couple of things in regard to this. One was really on the therapy organization, as in, do you find yourself introducing cannabis when, as you were saying just now, anti-epileptics tend to be like the drugs that is used, but it's not always really resolutive. It's not a resolution quite often. And so I was wondering, do you try to add cannabis to an anti-epileptic and see whether like this combination actually works, or do you rather for the patient to drop out a medication that is using but perhaps is not really helping with the pain? And then the second question that of course came just spontaneously when I think about the endocannabinoid deficiency is that often this is associated mainly with women more than men. And in fact, the incidence of these pathologies, like you just mentioned now, also GI issues like IBS and fibromyalgia, there is so many actually that are, even depression, that are pathologies with a higher women incidence. And so I was wondering if you, in your practice, you see this, and what's your different approach in between the two genders? And I'm just gonna hide myself back again. Thank you.
So, Viola, thank you for your questions. These are very, very huge topics, so I'm going to try to address them very quickly. So, I will start with the last one. So, yeah, it is a disease, a pathology of women, but it is not as seen in the clinic. So, basically, if you look at the epidemiological studies, you see that there is correlation between, of course, much more women are affected by the condition, but it changes very much together with the changing of the criteria which are used. So basically, in the 1990s, the tender points were used. So they began to use these tender points kind of objective evaluation, which was then dropped out because it was not objective at all. And also, it found much more women than men because women are much more sensitive to touch than men. So when you base your diagnosis on touch, so on tender points, you find much more women. So at one point, we were at a point in epidemiological studies where you found 10-to-1 women to men ratios. Then we progressed with the clinical diagnosis, with the clinical criteria, and then the tender points were completely abandoned. So it is kind of wrong nowadays to diagnose fibromyalgia with the tender points, which many of my colleagues still do. But so they were abandoned, and progressively they found in epidemiological studies, they found more and more men affected by the condition. So to get just with a cluster of symptoms. And nowadays, the population in the clinic is still more or less 9-to-1 female to male ratio, but this is because the diagnosis is not very well done. So probably there is an underestimation of the population of men who have fibromyalgia. Apart from that, I must say that, of course, it is more frequent in women, but it is more frequent also because of the increased frequency of autoimmune diseases in females. So it is fibromyalgia is very correlated with autoimmune diseases, as we saw before. So it is probably correlated with some autoantibodies. It is correlated with the inflammation, peripheral inflammation that sensitizes the system. And so probably it is because of that. So we have more arthritis female patients, and we will have more fibromyalgia female patients. But it is probably much more underdiagnosed in men. So the fibromyalgia men that we see, at least that I see in my clinical, we see in Italy, but it is a very worldwide problem, are much more severe because they are kind of full-blown fibromyalgia. So you may do an add-on therapy for them regarding cannabis. So I will then skip to your first question. So you want to do an add-on in that case. So if you have a very severe patient who tolerate the other drugs, but they are not very satisfied with the treatment, but they think that they feel that they have benefit from this type of treatments, you may want to do an add-on treatment. Whilst if they see that these drugs probably don't work, you may want to switch. Also, it depends on the side effects. So you remember that probably maybe you know that that cannabis has a side effect regarding, for example, dizziness or lightheadedness, and maybe it can give some kind of cognitive problems. So if you have a patient who has a lot of cognitive problems, which is called the fibrofog, so the mental fog of fibromyalgia, and has a lot of these problems, and it takes antidepressants, mostly anticonvulsant, that gives this problem. So there is an exacerbation of this fibrofog. You don't want to give cannabis on that because, of course, you may worsen the situation when you increase the cognitive disturbances. So and also there is a problem with the dry mouth, for example. So there are some maybe adverse effects that you want to consider before starting a cannabis as an add-on treatment in your patients. I don't know if I answered to all your questions.
It was fantastic. And actually, you already replied to one of the questions that I already wanted to give you, which is I didn't know that one of the symptoms as well of fibromyalgia is that of like drying mucus, and I was wondering, how do you deal with that in terms of, well, we know that it's a really unspoken side effects of cannabis, but xerostomia, it is a thing. And so I was wondering if you notice any difference with like maybe switching method of administration or switching ratio of cannabinoids, or if it's like just not applicable as a treatment for the patients that really have already like a dry eyes and dry mouth situation.
Well, again, it depends very much. So there are some patients who have a lot of dry mouth, but they say, okay, I just use a gel or whatever. That, as you may know, Zika syndrome is very prevalent in the connective tissue diseases. So if you have a Sjogren patients, you don't want to give more dryness. So it really depends on the person, and of course THC is very much associated with that. So you may want to decrease a little bit the THC if you don't want the patient to experience dry mouth. But there are some patients who, for example, prefer not to have so much pain but having dry mouth. So it really depends on the person. So they may have a lot of stiffness. They may have a lot. Oh, one thing that I didn't say is the stiffness of the muscles, which is very much implied in the pathogenesis of the condition. So myofascial pain syndromes. So you may want to add a little bit of myorelaxant effect to that. And the myorelaxant effect, for example, myorelaxants, aceclbenzaprine, is very much used for fibromyalgia, but it gives a lot of dryness to the mouth. So you don't want to put these two things together. So yeah, it's a personalized, tailored treatment.
I got you. I was sorry, I'm Fabio. I'm stealing you like a lot of questions, but I was wondering because you said the diagnostic used so far, which I totally, yeah, I see it because it's been so underdiagnosed. Fibromyalgia, it was actually non-correct. So what's the go-to diagnostic tool, if there is any? And then I wanted to take a question of an audience that perhaps is related to this. I'm not sure. Is there a non-invasive way of measuring endocannabinoid receptors? Would biopsies be the only way? I can reply to this as a preclinical scientist that was working on receptors, but I don't know whether this question is more like on the assessing and diagnosing the disease, or checking out how is the current state of the endocannabinoid system. So maybe you can give us like a bit of an insight on what's the diagnostic way to go, if we want to be precise about fibromyalgia, and perhaps Christina can add on to this question to let us know whether we are getting it right or not.
Yeah, so actually there are lots of aids to diagnose, but they're all questionnaires or clinical help. So there is no way to have a biomarker for the disease still yet, but you have some questionnaires that can provide you with a screening. So there is the SIFIS, for example, the CFIS score, which is a screening for example, the general practitioner who can use. And actually the latest criteria, which are validated by the American College of Rheumatology, the most important ones are the 2011, which is a revision of the 2010 criteria, are a questionnaire. So basically it is, you have to ask your patient, and after a while you can kind of recognize a pattern. So there are some symptoms that have to cluster together, and there is a particularity. So for example, the hypersensitivity to external stimuli is very, very peculiar to these patients, for example. Regarding the ACB, by the way, I wanted to just add a thing. As you said, it has been hypothesized that fibromyalgia is an endocannabinoid deficiency disorder. Actually, the latest study have found there are very, very few studies, like 2 of them or 3, that found that actually these patients have higher anandamide and other endocannabinoids in the blood, and I think in the CSF. But probably, and I don't think the receptor availability has been measured, but it probably happens as it happens with the opioids. So the opioids are a lot of circulating opioids in these patients, but the mu opioid receptor are low. So the availability of these receptors are very low, and this is why naltrexone is very appears to be effective in this population. So probably there is an imbalance, not really a deficiency, as called in this type of population.
Yeah, I thank you for clarifying this. I agree that it's an old term that is not, yeah, because it's not it's a disbalance, it's not a deficiency, absolutely. And actually, thank you for prompting us. We should definitely, this came to my mind already with our previous guest, with Dr. Ines Reynoso, to talk about 2AG, because I think it would be clearer on why there is an overabundance of 2AG in an inflamed tissue. So I think it's a very fascinating topic. Actually, I had a 2 hours conversation afterwards with a friend, just talking about anandamide and 2AG in the brain and the effects on amygdala and fear perception and all of that good jazz. Which I think it's one of the roles of 2AG and its implication actually in the of anxiety and mood disorder for fibromyalgia. But I see that our time is running out, so perhaps we can finish to reply to our Christina. I'm wondering, sorry.
Yeah, maybe I can reply to Christina, because it's not possible to measure endocannabinoid receptor because they are expressed on the cell surface or sometimes also on the mitochondria. We have cannabinoid receptor expressed in the mitochondria, so it's not possible to measure endocannabinoid without taking the tissue, and this is very complicated because we cannot take, for example, brain tissue from a patient very easily, so it's not easy to measure. Maybe they can do like post-mortem studies to evaluate this kind of the expression of the receptor, but it is not possible in other ways.
Thank you. Yeah, of course, we're talking humans, so it is possible, of course, on cells and tissues. And
yeah, it is possible to measure the levels of the endocannabinoids, circulating endocannabinoids, and as Valeria was saying, they measured and they found that probably anandamide is overexpressed in some fibromyalgia patients.
Yes, and I confirm what Christina is saying, that it is very invasive, because when we want to, at least for now, when we want to measure endocannabinoid levels, it is a matter of taking the cerebrospinal fluid. So as you can imagine, it's not something that you are compliant and willing to do on a daily basis. So I'm seeing here and there tests to test the endocannabinoid system that are based on saliva. I really would like to enter this and understand better the mechanism on which they function, because I would like to remind you that endocannabinoids are also expressed on need. So it's not like other neurotransmitters that are stored there, and we can check whether we have enough. And really last question, and this is for Valeria, and then we say to all of you goodbye. What about samples from pap test? Is this gynecological analysis? Sorry, I'm really ignorant on this stuff.
Yeah. Pap test, Papa Nicolau. It's from the cervix. Not really, as far as I know. Nothing has been tested with pap tests in fibromyalgia patients. I don't know. There is a lot of comorbidity, of course, with chronic pelvic disorders, because what I've not said is that, what I forgot to say is that there is a lot of comorbidity with the chronic idiopathic painful condition, the other idiopathic painful condition. So since there are a lot of chronic painful condition, I don't know if it is very feasible to do the pap tests in this population. They are very, very painful. They have a lot of vulvodynias, endometriosis, and so on. So it may be, of course, confounded by this type of conditions, and also it is very difficult to take a sample for these patients, also from my personal experience. So I don't I don't know. As far as I know, there is no experience on that.
Primum non nocere. Ladies and gentlemen, since it was live with all Italians actually on board, well, of course, we went overboard with the time, but now it's really the end of it. I remind you that next week, next Tuesday, same time, 5:30 Central European time, it will be auf Deutsch. So all of you that want to practice or learn some more, all in German, it will be with German patients exploring a bit more what's going on in there. So we'll see you and catch you up there. Ciao.
Goodbye, everyone.
Goodbye. Thank you.